We're doing task number 6, monitoring anesthesia using an anesthesia chart. We have our chart right here, and a live patient that we're going to be doing some different, showing some different reflexes and different things on that you would monitor during anesthesia. Also have some pieces of equipment, not all of them. The anesthetic chart has places for what time it is. It has all the medications and everything on it, the patient's name, and then it also has room for every 5 minutes during anesthesia to take their vital signs, so heart rate, respiratory rate, blood pressure, CO2, SpO2, what fluids they're on, what ISO level they're on, what level their oxygen's on, temperature, and that sort of thing, so we can keep up with it through the surgery. This is Lottie. So the first vital sign that we're going to talk about is heart rate. Heart rate can be assessed by 3 different ways. You can feel through the thoracic wall, feel for the apical beat. You can also, it's more of the pulse rate, but you can still evaluate if the heart is beating, what the rate may be by feeling the femoral pulses or just a pulse anywhere on the body. You can also listen via stethoscope or like an esophageal stethoscope. So usually heart rate does decrease during anesthesia. So for dogs it may be between 60 and 150 beats per minute. Cats may decrease to 120 to 180 beats per minute. During stage 3, plane 1 of anesthesia, the heart rate will be strong, usually normal, greater than 90. In stage 3, plane 2 of anesthesia, the heart rate will decrease a little bit because they're in light anesthesia. And then stage 3, plane 3 of anesthesia, their heart rate is lower, their pulse is lower, and they're going to be kind of at an even rate. So the next one is heart rhythm. Heart rhythm is assessed via an intra-arterial catheter, blood pressure. You can also, the most common way is to look at an ECG reading during surgery. Normal sinus rhythm is usually normal for healthy dogs. Occasionally you may see a sinus arrhythmia in young and healthy dogs. If you see arrhythmias, usually they're either because of diseases or they can be because of drugs. So it just gives you a good idea. Depending on your patient, you can see, you can usually guess if they're going to be having arrhythmias. If they do have arrhythmias, your anesthetic chart will have information on what drugs to give, and dosage is already calculated, so that saves you time during surgery. The third thing we're going to talk about is mucous membrane color. So mucous membrane color is an indication of tissue oxygenation in the tissues. So you can evaluate that via the gums. You can just press your finger lightly. It'll turn white because it's blocking the flow to the small capillaries, and it should turn back to pink within 2 seconds. If it's prolonged, there's an issue with perfusion. You can also evaluate mucous membrane color in the lower lid conjunctiva. You can also evaluate it in sometimes the ear. Sometimes it doesn't always work on the lips because pigmented, or their tongue because of pigments in the gums. You can also use the skin around their prepuce or vulva. The next one is pulse. So pulse can be evaluated through several different sites on the body. You can do a dorsal pedal. You can do the femoral, is usually an easy one to feel for. Usually it's a rough indicator of what the blood pressure will be. In our hospital, we usually say that if you can at least feel the pulse, but you can't get a blood pressure, then your blood pressure is usually around 60, but it's very rough, so it's just more of something that you would evaluate before surgery, so you kind of know what's going to be normal for that patient, and it does decrease during surgery. You should feel the pulse after each apical beat. So if you're listening to the heart, the pulse should be pretty much synchronous with when you feel that. The next one is blood pressure. So in this hospital we use a Doppler for our blood pressure. So we'll connect, we'll use the little probe right here with some ultrasound gel on it. Usually during surgery we try and use the front limb and use the dorsal pedal. Sometimes the tail is pretty accurate for cats. This is usually 60 to 150 millimeters of mercury. during anesthesia. You never want it to decrease past 60. It can vary depending on what cardiac cycle, or the cardiac cycle, so whether you're listening in at different ventricle beats and different, just depending on how the heart is beating, and when you listen into it at that second, it may vary from time to time. It can be altered due to drugs. It can be altered due to anesthesia. It can also be altered due to surgical stimulation, depending on if they're on nerves or different veins or stuff, and also hydration status. The next one we can talk about is respiratory rate. So respiratory rate is easily viewed by looking at the chest wall. It's harder to listen to respiratory sounds during anesthesia because respiratory sounds are going to be decreased. So you usually just watch and make sure that the chest wall and diaphragm are moving at the same time. You can also look at the ventilator. If you do have your patient on a ventilator, then as long as the ventilator and the lungs are fulfilling at the same time, you know that the endotracheal tube is in the right place. There's also, you can look by looking at the reservoir bag. So if you don't have your patient on a ventilator and on a reservoir bag, it may be easier to look at the patient's reservoir bag, especially if they're under a drape, surgical drape. During stage 3, plane 1 of anesthesia, their respiratory rate is going to be normal, usually 12 to 24 beats per or breaths per minute. If it's stage 3, plane 2 of anesthesia, that's going to be a little bit decreased, and then it really decreases, and is usually under 12 breaths per minute when they're in stage 3, plane 3 of anesthesia. Sometimes respiratory can decrease if you give induction agents such as propofol or thiopental too fast. And it's also, respiratory rate can be evaluated for the number 1 sign that your patient is waking up from anesthesia. So they may have increased respiratory rate, their chest may be moving a little bit faster, and you know that that's kind of the first sign to watch out for when they're waking up. Respiratory rhythm is assessed during the same time when you're looking at the respiratory rate. You just want to make sure that it's normal breaths, it's not gasping, it's not increased effort on inspiration, it's not increased effort during respiration. If they're having difficulty breathing, if they have some kind of disease process, and they may have increased effort, depending on whether it's during inspiration or during expiration. During usually normal breath sounds, respiratory rhythm during the first 2 stages, or first 2 planes of stage 3 of anesthesia. During stage 3, plane 3 of anesthesia, usually you'll see a little bit more shallow breathing, and usually that's when you are going to want to squeeze your reservoir bag every few minutes to make sure that they're getting full breaths. And also why in a lot of our surgical patients we use a ventilator, because we're keeping their respiratory rate in a normal rhythm. The other one that we're going to talk about is body temperature. So body temperature is evaluated either by their rectal, I'm not going to do that on Lottie, she probably won't like that, but during surgery you can use a continuous monitor through their rectum, or you can also use an esophageal probe, so you just put it right next to the ET tube, and it won't go down into the trachea. Obviously it'll go through the esophagus, and you want it to be just under the heart whenever you put it in. So you always want to measure from their mouth to about middle of their chest, and make sure that you're going to put the probe that far in. That way you get a really accurate reading of what their body temperature is. Body temperature does normally decrease during anesthesia, so that's hypothermia, is something that you always want to plan for when you're putting a patient under anesthesia. So most of our surgical procedures, we usually, if it's on a wet table, then we're going to fill it up with warm water. If it's on a surgery table, then we're going to use a warm water towel, use a bear hugger, those sorts of things to keep them warm and a normal body temperature during surgery. You always want to plan for it. You never want a temperature to go under 96 degrees Fahrenheit. If it's under 96 degrees Fahrenheit, you're really going to have issues with your patient waking up, because their metabolic rate is going to slow down a lot. The greatest loss of temperature is usually during the first 20 minutes of anesthesia, so your temperature is going to drop the most during that time, and then hopefully it's going to plateau out. But you're always going to be using a bear hugger or warmies of some sort, warm fluids, just to make sure that their metabolic rate is going to be at a good enough temperature to where their body's going to process drugs that they are using. Occasionally you'll have an issue of hyperthermia. A lot of times that happens when you give cats opioids, like ketamine or morphine. Sometimes those can cause cats to have a higher temperature, so that's something to watch out for. If you overheat your patient, you may have an increased temperature. It's very rare that happens, but you may see it, so it's good to watch out for. Another vital sign that we're going to watch for during surgery is the pulse ox readings. It's another way just to make sure, kind of like watching the mucous membrane color, watching the capillary refill time, is making sure that the tissues are perfusing properly. It's going to look at oxygen saturation. You always want oxygen during surgery to be above 95%. If you're giving 100% oxygen and it's below 95%, then you've got an issue, and you either need to wet the tongue, find a new place. You may need a new probe to put on the tongue. If it's between 90 to 95, you've definitely got an issue. Obviously, you need to move it around. It becomes critical for patients when it's below, the pulse ox reading is below 80% for more than 30 seconds. That's when you're going to have more issues with their organs because they're not getting the oxygen that they need. A lot of surgeons like to use the capnograph instead. Well, they use both of them. The capnograph usually is a better option to view how the patient is doing under anesthesia, because you know for a fact how much CO2 they're breathing out. So usually for a normal patient, upon expiration, normal CO2 readings are going to be between 35 to 45 millimeters of mercury. If it is higher than that, then it may mean that you need to increase the respiratory rate to get that CO2 out of the lungs. Usually this is caused when you're not ventilating enough, so you're hypoventilating the patient during anesthesia. If you're having a very low CO2 level on the reading on the capnograph, it means you need to decrease the respiratory rate because you're hyperventilating them. They're breathing, they don't have time to take a deep enough breath to get all the CO2 out of their lungs. So it's a better reading. A lot of surgeons like to see CO2 readings more just because it's more accurate of how the patient is breathing under anesthesia. Waveforms we also evaluate during surgery. So on our VETT monitor, it should look like a slow or gradual increase. It should plateau and then it should drop back down. It should always be 0 millimeters of mercury upon inspiration, because they should not be breathing in any CO2. All right, so what we're going to be doing now is looking at